Great. Well, hello, everyone. Good day. I know it's different time depending on where you are, but the sun is out in Washington, D.C. I hope similarly nice weather for wherever you're zooming in from. If you don't know me, and I do think I know pretty much everyone on today's session, I'm Abra Lyons-Warren. I'm the Director of Cross-Sector Initiatives at CLPHA, the Council of Large Public Housing Authorities. This is part of our Housing Is Working Group webinar series. So we're excited to have you join us. This is one of our more kind of traditional webinar presentations. We will have time for questions at the end. Feel free at any point to put something in the chat if that, a comment or a question, if that's useful to you. If you don't want to forget, that's fine. I think we're mostly, just glancing over, mostly housing authorities joining today, maybe a couple other folks. As a reminder, these presentations are open to the broader public, just so that you have that in mind, compared to our roundtable sessions, which happen quarterly, and our update sessions, which happen biannually, which are just for CLPHA members. But today, as you saw, we are recording, and there may be outside folks who join, just so that you're aware of that. Before I hand it over, I want to make a quick plug for our annual Housing Is Summit. I know some of you have already registered, are involved in presentations, or are attending, have come in the past. You can check out more information about that with the link that Camille just put in the chat. But this is our annual event where we bring together all the different housers and educators and health folks and government and philanthropy, and put everyone in the same room and form more partnerships. So it's really a fantastic event. This year, we're so pleased to be able to focus, deepen our focus on maternal health equity. You know, we had a session on that last year, as well as our partnership with the White House this past January. We're doing a focused look at some financial programs for low-income individuals and families, at literacy, tons of different topics. So more information at the link with the agenda, as well as information about registering. We do have options for both in-person as well as virtual. So we'd love to have you join us. And with that, I am so pleased to turn it over to Stephen to let him introduce himself further. And you'll also be hearing from Camille in just a little bit with some news from the national lens. Stephen?
Thank you very much, Abra. Thank you for giving an overview about CLPHA. My name is Stephen Liang. I am getting ahead of myself here. We have an introduction panel slide here that will be coming up. So let me go ahead and allow me to go ahead and begin sharing my screen here. Okay. Okay, is everyone able to view and see my screen here? It should say residents and behavioral health crisis. Is that
Yes.
correct? Okay, excellent. Okay, excellent. Well, thank you so much. Welcome, and thank you everyone for being here with us. As you can imagine, we want to see if you guys are experiencing and similar challenges in your own communities. We hope that by sharing our challenges with you today and some of our efforts to date, we can create a learning community and work together on increasing the federal support for our residents. So moving on to my introductions here. So my name is Stephen Liang. My position here at the Seattle Housing Authority, or SHA, is Senior Property Manager. I will go ahead and allow from the top to bottom for the panelists today to go ahead and introduce themselves. So Jake, I've got you next.
Good morning, afternoon, everyone. My name is Jake LeBlanc. I'm a property management administrator here at Seattle Housing Authority. My team and I have housing responsibilities for several different portfolios of housing, about 1,000 units of senior housing in the city of Seattle. We help manage about 1,200 scattered sites or larger bedroom size units. And then we have a kind of hodgepodge portfolio called Outside, where we have 1,100 units that are both market rate and subsidized. And then the focus of our presentation here today is our public housing high-rise units. There are about 3,200 of those units, and those are predominantly studio and one bedrooms. I've been at SHA 22 years in a role in property management roles, and I've been an additional 8 years of other housing responsibilities at nonprofits, both in Seattle and other parts of the U.S. Thanks.
Good
Rachel.
afternoon. Good afternoon. I'm Rachel Steward, and I'm the administrator for the Community Services Division here at Seattle Housing Authority. I joined SHA in 2018. Next week, I'll transition into a deputy director role for housing operations. I've been very excited to be supportive of the community services team and the agency overall, and ensuring that our residents have low barrier access to supports and services that improve the quality of their life while maintaining dignity as well. We also are active in maintaining and building the leadership skills of our residents such that they can be contributors in our buildings, properties, and communities at large.
Well, hey, everybody. My name is Sean Walsh. I'm a supervisor at the Aging Disability Services in the City of Seattle. I may be an outlier here. I think there's a lot of housing, primarily people here. My particular role is to manage a team of case managers that work through the City of Seattle and through the state of Washington's long-term care system, really deeply interconnected with SHA staff and other providers. We do office hours. We administer long-term care service programs in SHA. This is a program that's been going for about 25 years. I've been in and around it for about 15 of those years. And and as the topic, we'll get to in the topic, seeing a lot of changes in the behavioral health nature of the residents that we're serving and in the service mixes that we have. And I just want to say thank you for the nice wishes for warm weather. It is actually freezing cold here in Seattle, and it's snowing in Portland 3 hours south of here. So please send spring soon. We need it.
Perfect. Yeah, it is cold in Seattle right now. They teased us with some warm weather, and then they took it away. So just a couple of things to add. I've worked with Jake for a long time, as well as Sean. And for myself, I have about 9 years of housing experience with SHA, and then as well as an additional 3 years. So I've been working in the industry for 12. So thank you, panelists, for your introductions. For the next national context slide, I'm going to go ahead and invite Camille to go ahead and join the presentation and share with us the national context.
Yes, thank you. So I have to say, I know Seattle Housing Authority is not alone here with their challenges. I've certainly heard it from PHAs across the country struggling with similar challenges of supporting their residents when they're experiencing mental health needs and behavioral health crises. You know, across the country, even prior to the pandemic, we were seeing a rise in suicide rates, particularly between 2007 and 2017. Suicide increased 56% among people ages 10 to 24, becoming the second leading cause of death for this age group. In 2018, we saw 48,000 individuals die by suicide in America, with a recorded 1.4 million suicide attempts. Beside that, the opioid crisis has not gone away. While the number of overdose deaths had decreased prior to the pandemic, this has increased during COVID-19 as well. And then also, sorry, I lost my notes. Also, COVID-19 has exacerbated these mental health challenges across the country. In the US, the adult population has reported to experience increased level of mental health symptoms, including anxiety, depression, trauma-related symptoms, increased substance use, and increased reports of serious suicidal ideation compared to pre-pandemic data. This has been especially felt in populations overrepresented in our PHAs. Particularly, this has been larger in Black and Hispanic communities and essential workers. This is an ongoing challenge across our country, but certainly our PHAs are seeing it in a different light. We're excited to hear from Seattle today about both a real look into the challenges they're experiencing, as well as some of their ideas about what they're going to do with it. We'd love to hear from all of you all as well, to chime in with your challenges and ideas. I'm going to turn it back over to Stephen.
Thank you, Camille. So the next slide here, just want to give you guys a little bit of local context. Jake did a good overview of kind of the portfolio that he oversees. For myself, my role as senior property manager is with our low-income public housing high-rises, and we separate that geographically. So I manage the north end properties for Seattle. But in a bigger picture, the Seattle Housing Authority serves more than 18,000 households in a range of different settings, including the high-rises, garden communities, scattered site apartment complexes, single-family homes. SHA has a large portfolio of vouchers, tax credit units, and other types of affordable housing. Today, what you'll see here in the webinar focus specifically on our high-rises, which we have 3,300 units or so. Half of those are managed by myself. The high-rises are mostly one bedrooms and studios, and the individuals, they have a lot of individuals that live there, as well as a couple of larger families or so. So that's kind of a local context for everybody. Just going to highlight here, show some folks, show you guys some pictures from some of the challenges that we've been handling or facing. So a couple of these photographs here, you can see some of the property damage that's been caused by some of the some of the mental health behaviors and kind of the environment we're dealing with. Here you can see one of our residents in crisis. This is this is kind of an example of some of the behaviors that we've been having challenges with. So, okay. For this slide, this one, I'm going to go ahead and introduce, have Jake go ahead and present here for slide number 8.
Yeah, thanks, Steve. As all of you can imagine or possibly know, there have been many unexpected and expected challenges with the COVID pandemic. We, of course, included pics, and Steve talked about some of those just a moment ago. Quite frankly, we could have done a full presentation with many, many pictures just on these kinds of incidents. And those of us in the large housing authorities and other public housing authorities, I think we're used to these kinds of events. But what I would say is what is totally unprecedented for us here at FHA is the frequency, the severity, and the repetition of these types of events. As Steve mentioned, he works in the North portfolio. He has 15 high-rises. There are 28 total in this portfolio. And I would offer to you guys that not one of those high-rises has been spared within the last year or so. Moving on to slide number 8. An intersecting set of circumstances have created an unprecedented level of crisis in our public housing high-rises. The pandemic, drug use, and crime have created crises that are separate but disproportionately impacting the high-rises. Unsheltered homeless people and unsheltered homeless communities in the Seattle area are also increasingly impacting the high-rises. In the past, our high-rises could count on some of the following services. We were, of course, able to have case management on site, and Sean and Rachel are going to talk about that in a little bit more detail in a moment. What changed with us in the pandemic is that we weren't able to have the case managers on site. They've done work with us through phone calls and other methods, but they haven't been on site. What we could count on in the past is a unique arrangement that we had with the Seattle Police Department, where we had several community police team officers, CPT officers on site, and they worked with our property managers and checked on our buildings, and we even had some patrolling at night. Through that same contract with SPD, we were able to receive police notifications of incidents from the prior night or even the last couple of days. These were incidents that we might not have heard about, and it gave us an opportunity to process them as property managers. We were also, through that same contract, able to have officers present for property management staff to go door to door or deal with lease enforcement actions. These Seattle Police Department resources are no longer available to us as of this moment in the city. Turn it back over to Steve to talk about some of our staff experience.
So for for ourselves, as far as my program and similar to a lot of the other programs across the board, we've been seeing shortages in our staffing. Property assistants, which are our custodial staff, have been in work fatigue and have had quite a bit of turnover during the course of the pandemic. We also have the dealing with physical threats at the work site, residents who are experiencing mental health crises, that their behaviors could become erratic, maybe even sometimes violent. Staff unable to work on site or out sick during the pandemic. We contact tracing and having to deal with the the outbreaks in certain areas of the work. The Omicron variant really hit us hard in the month of January for a lot of staffing. Maintenance workers are also on a shortage in trying to get units turned over, work orders maintained and managed, and getting just the bare basics done for unit repairs. And then challenges in the hiring of quality candidates is also hard as well, because just kind of the pool of applicants that you're pulling from are very limited. So that's been the staff problems that we've been going through. So the next slide here, we wanted to highlight some more photographs of kind of what's going on here. This unit here was burnt down due to a fire. I responded personally to the fire after the aftermath. Something to highlight here is the resident here. I was sitting there talking with her in the office, and as you can tell, if you can see in the photograph here, her over her right shoulder is kind of a scarred and burnt up sweatshirt that she's wearing. And this resident was dealing with a mental health crisis. We had been trying to get her assistance during that time, and even to the day of the fire and the evening of the fire, she thought that she could go back into her unit here, pictured on the left, to go back to sleep so that she could go to work the next day. And I had to keep explaining to her that you're not allowed to go back into your unit. It's been condemned by the Seattle Fire Department. So this is one example of some of the things. This is probably one of the more extremes, but this is just some of the challenges we were dealing with during the course of the pandemic. And this was back in May of 2021. And so that was something we were dealing with there. For resident trauma, many residents have experienced trauma in their lives. I'm sorry. I think I've intruded on Rachel's side of things, actually. Rachel, I'm going to hand it off to you to go ahead and explain this one. Thank you.
Thank you, Stephen. Sean and I are going to tag team over the next couple of slides. Sean Walsh from Aging and Disability Services from the City of Seattle is a key partner to us at Seattle Housing Authority, as well as a number of other contracted partners, including Full Life Care, Sound Mental Health, Southeast Youth and Family Services, and Neighborhood House. I mention them because we'll talk a little bit more in depth about the critical need for community partners. But in terms of being able to be clear about the condition that our residents come to us in, we wanted to spend some time very briefly just talking about the trauma that individuals experience as a result of race, as well as income. And we find that our residents are often a part of communities that are marginalized from the very beginning because of race, because of ability or disability, visible and invisible, that oftentimes results in them being in a lower income strata. What we have found of late is that in the past, in public housing, our residents have been more challenged by just being low income and less by also having additional abilities and disabilities, and they are not supported in other public settings to the degree that they were previously. So in very simple terms, our state mental health hospitals and state functioned systems were not or are not functioning in the way that they used to. And in some cases, that's for good reason, right? So there are those of us who know, oh yes, I have this family member who was sent away, right? And we didn't see them anymore, and they were raised in this place or that place, and that ended up not being so good for them. And so the result in seeing that there were problems is that many people are now left to be cared for individually by families who are not prepared and resourced to do so, or they are out on our streets. And then those of them who are able to get support to navigate the systems land in our public housing, which is better than being in the streets, certainly, but they are not getting adequate care. And Sean, I'd love for you to be able to chime in here and talk a little bit about some of the residents that we have who rely on long-term care systems to be able to be supported.
Sure, thanks, Rachel. And I know some of the next slides also talk about like what you were describing, the incidences of behavioral health issues being higher in public housing buildings that we serve, which is something that we observe also. And just specifically about our role, you know, we in the long-term care system, we're dealing with older and disabled adults generally, but more and more there's an overlap of behavioral health, really complex behavioral health issues that include things like hoarding, that we've tried to bring in the system of things like home care workers and, you know, alternate care settings to try to support. The amount of services needed that really are pertaining mostly to behavioral health needs as opposed to functional needs has really changed a lot in the last few years. And the pictures you're seeing about the burned up units, we could show you dozens more of like hoarding units where people have this disorder of hoarding, and there's not a system of support like there is in the long-term care system of caregivers that can come in. SHA, I'll just say, has done a really fantastic job of partnering with different providers over the many years and built a care network that it is including more behavioral health support over time and hoarding support, and recognizing that you really do need to bring services out to people. The behavioral health system in Washington is not designed to bring the help out to people. It's clinic-based. You have to go to a clinic, and really to draw it into the communities in the same way that long-term care services have is really, I think, a positive, good direction for SHA. And at the same time, we're facing what you've heard earlier, that the response to behavioral health needs in our area has been by law enforcement. It's been sort of decriminalized, and it's not, you know, that, which is, I think, a good thing. It should be, these are issues that should be addressed by behavioral health and mental health and community support rather than law enforcement. But what that's left is a whole series of situations of what do you do when you have somebody decompensating and either directly or indirectly threatening somebody else, or, you know, passively threatening an entire community by having a unit that is combustible, literally, you know, if it went up in flames would destroy a building. And so we've all been struck with this sort of set of challenges around how to deal with behavioral health issues in the absence of a system that sort of, you know, naturally comes into the communities that it's supposed to serve. So I don't know, Rachel, I can say more, but.
Well, I think with that segue, I think we want to go ahead and move on to the infographics. So we're going to go ahead to the next slide.
So this slide is just a visual representation of some of the data that indicates the use of behavioral health services or mental health services amongst our residents in the high rises compared to those individuals who are not receiving housing assistance. There are some different conclusions that can be drawn from this data. One, showing that individuals in our housing have high needs and they are utilizing services, and yet their needs are still not met. We can also see that individuals who are not in housing may have a higher set of needs, and they're not able to receive those supports because they are not in stabilized housing, right? So when we're talking about housing as a foundation for health support, this is a great demonstration or visualization of that understanding, but housing is not the only solution. And so here's just example of why it is so important for us to be able to partner in unique ways and be pushing both within housing, but also within the healthcare system to find ways for us to integrate our work such that we're able to bring services on site and not in a delayed fashion. So one of the things that is so important for us to talk about is the immediate response system that we need and do not have. And within the city of Seattle, as there have been efforts to create correction in law enforcement practices, there has been, we have not yet figured out how to rebuild the system and the structures to be able to create an immediate response with the needs to, or with the services to meet the needs of the people. So that is to say, as Stephen was giving the example in one of the prior slides of the burned out unit there, that resident had shown need several times before, and 911 had been called, and there was not a response. And there wasn't a response because we could not point to a specific health need that first responders would find adequate. And there was not necessarily criminal activity. And we do not want to criminalize someone who's having a health emergency, but we do need individuals to be able to identify a mental health emergency compared to a physical health emergency. And so it's a really good example of how someone is displaying needs that we could try to attend to, but then we know that they really do need to have a change of environment in order to be able to address the acute symptoms that they're displaying. You want to go to the next slide, Stephen? And SHA is Seattle Housing Authority. You can see here that there are, so in this particular slide, we're looking at the very extreme behaviors of psychosis, adjustment disorder, disruption, impulse control, and matters of conduct. So in other words, individuals who have trouble navigating socially and managing challenging situations when they come up. There are a much higher incident of those individuals in our housing than there are outside of our housing. We are an independent houser. We do not have nursing staff or individuals on site 24/7 who are trained to de-escalate and maintain relationships with residents that are therapeutic. We instead have partnerships that allow us to create referrals. And then we need to make sure that our residents feel compelled to accept the services offered through the referral. Sean, maybe you want to talk a little bit about what that referral process looks like, and we can toggle between this slide and the next slide to understand a bit of the network of service providers that we have available in that particular referral service environment.
Sure. Yeah. And you know, on the one hand, there's a sort of the curse and blessing. SHA has done a really great job of collecting a lot of different providers who can respond. And then the question becomes, well, who is the right provider? And I think the concept of a network is a good one, where you have providers that are talking to each other and talking to SHA and sort of able to figure out, okay, who is the best responder for any particular situation. It creates a resiliency, and I think we've seen that play out in a lot of different scenarios that have, you know, we've either crises or, you know, we had very successful COVID vaccination clinics, but in part because we had many different providers sort of engaged, reaching people from different angles. And so you know, the referral process, it depends on having created a network where providers are talking to each other. So for example, if one of our staff receives a referral from an SHA staff, one of the first things we're doing is checking to see if one of the other providers may be serving this person already, doing a little triage to find out, is this primarily a behavioral health issue? Is it a functional issue? Is it something that's more of a, a social community kind of type of response? And then deciding who the best person is to respond to that issue. We've started a monthly portfolio meetings with each of the smaller portfolios. Stephen leads one, and there are a couple of others that happen, and those have been fantastic. One of those, unanticipated great consequences of COVID is that everybody knows how to do video conferencing. So you don't have to sit in traffic for 2 hours in Seattle trying to get to the same room. You can do it like this right now and talk to a lot of people. That's really helped us sort of talk through what the needs are and who staff challenging clients. And it has allowed us, I think, to better integrate. When you're looking at those list of providers, we're ADS, Aging and Disability Services, City of Seattle, and we're tied into the big long-term care network of home care services. Full Life Care is a nonprofit that does a variety of services, including providing on-site home care and behavioral health. But Sound is the major behavioral health provider in King County for low-income adults. And the strategic partnership to bring them in has been going on for a couple of years, and it's taken time because it's not a natural thing for the behavioral health system to do house calls. It's just not. And that's unfortunate, because if you don't, you're going to miss a lot of context and a lot of where the real need is. And especially because we don't also have, in the long-term care system, you have housing. If you get functionally disabled, you can step down into adult family home, assisted living. In the behavioral health system, there's not this sort of tier of different places you can go if you have behaviors that need to be managed. It's you're housed, or you're homeless because you've been evicted for your behaviors, or perhaps you're, involuntarily at a hospital or somewhere else. But there's very little of that in between. And that's, I know that's getting a little beyond what Rachel asked me, but it's sort of the fact that we now have that provider more in the mix of community partners has been really helpful, and I think is going to be the major focus for the next couple of years, is to even better integrate that group. And of course, if we had the behavioral health providers, they'd share with you the many challenges they have with staffing and with response, and the limitations of how they can respond. So I don't know if that's helpful.
Yes, thank you, Sean. And that final community partner there with all those letters is Southeast Youth and Family Services. And to speak to the importance of us being able to be nimble and responsive to individual needs, our residents, as many individuals across our country and communities, do have a number of different stigmas to receiving behavioral health supports, and in particular in communities of color, and especially within our Black and African American populations, there are several stigmas to get over receiving this particular type of healthcare. And everyone is also very careful about who they're willing to receive those health services from. So Southeast Youth and Family Services is a newer partner that we're bringing in to be responsive to our Black and African American community members who have in the past been less willing to receive supports from folks who don't look like them or don't have connection to the communities where they're coming from. So those are just a few snippets of information about our experiences and our hopes to be able to meet the needs of our residents, as well as support our staff. One of the things that we didn't talk about in the slides of this presentation is that prior to COVID, Seattle Housing Authority had partnered with Seattle Public School System to deliver trauma-informed care training to all of our staff members. And what we did that because of the partnership, the institutional level partnership that we have with Seattle Public Schools in trying to find ways to make sure that we were being thoughtful and responsive to the needs of young people and their families. This particular portion of the housing that we're talking about today primarily houses adults, but the trauma-informed practice, of course, is applicable across all of those populations. And so we've done our work to try and make sure that our staff have some of the knowledge and capability to be able to navigate what they're encountering with our residents, but we know it is not even close to enough. So thank you very much for allowing us to share with you. Stephen?
Yeah, so I'd like to go ahead and invite Jake to go ahead and present about what's next for us.
Yeah, this is Jake, and a couple things here we're working on here at SHA is we've increased our staffing for this particular portfolio by 14 new property management staff. And for example, we would have had 6 property managers managing the 3,200 units, and now we're going to increase that to 8 property managers. And we're hoping to get more eyes and more movement in our buildings to help monitor and manage things. A second thing we're looking at is we're working locally to advocate with the city for behavioral health connections for all of our residents. So I think we're running a little bit long on time. So Steve, I'm going to go ahead and take the opportunity to wrap things up. We appreciate you having sat through our presentation here today. We're going to turn it over to everyone for questions, comments, or anything you'd like to add to this presentation. And again, thank you for your time.
Yes, we have our mark at 40 minutes. I was gonna mention that when we got to the Q&A. Does anybody have any questions to ask of the panel?
We have one question in the chat from Gabriella. Do you all have security or police on property at all times?
I can go ahead and start with that one. At this point right now, security is being utilized at our more at the properties that need it the most. And so we've been experiencing there's been a lot of staffing shortages actually with the private security company that we hire. And so it's been hard to be consistent about coverage. And so, we assess which each property that needs it and how much of it they need. It because sometimes it could just be an evening detail, or sometimes it needs to be 24/7. And we've been managing it that way so far. So
Stephen, I would like to add that the answer is no. We don't have security at all of our properties all of the time. And what we have done is use private security companies to augment or supplement when some of the crises appear at some buildings and stuff. We did, as we mentioned earlier in the presentation, have a contract with the Seattle Police Department, and we had officers that we worked with, but at no point have we had security at all of the properties at any given time.
So I see another hand is up. Is Annie?
Hi, this is Annie Panucci with the King County Housing Authority. Wanted to say thank you to our close partners at Seattle Housing Authority for this excellent presentation. A lot of this is some of the things I know, but I love how you kind of put it all together to give us a picture of what you're dealing with and how you're responding. I also appreciated that you showed some of the data that we have through our partnership with Public Health Seattle King County. And so my question, I'm the director of research over here at KCHA. And so of course my question's about data. At KCHA, we hear a lot anecdotally about increases in behavioral health incidences, but we're working to kind of build a more systematic way to capture this and really more consistently define what we mean by behavioral health issues and needs, and capture it in a way to track trends and kind of design programming and response around it. And so I was wondering if you have any advice on this, like how you track this on a day-to-day basis, or if you kind of have a similar challenge.
This is Jake. I would say that we have the similar challenge and that you guys may be a little bit ahead of us. We're talking about a meeting with you guys a little bit later this year, and I'd love to hear more about the work you're doing, because I think we could benefit from what you guys are starting there.
I would mention, Annie, that Jake is correct, and we're utilizing our critical incident reports to be able to track and understand what's happening with residents and why a behavior is showing up. We do know from our trauma-informed training, right, that in many instances when you are seeing a behavior, it is a result of someone trying to cope with distress in an unhealthy way. So it's reasonable to think that as you have different incidents come up, that they could have behavioral health connections. I would also say that being able to share information back with our partners so that our partners are able to see and understand where folks are showing up in the systems and where they're tiered is also really important. And so it is an integration of information across different systems to be able to try and get an understanding of what sorts of causes are creating disruptions in the communities and in the various different buildings.
And if I could just add one other, there's sort of a connection SHA has through the fire department with a Health One. Seattle has a growing unit called Health One that incorporates social workers into the responses of EMTs and not so much police, but EMTs and fire department, who are often called out in, when there are crises. And so we do get referrals frequently from them saying, hey, there's somebody in an SHA building. We know you have case management there. Can you follow up with them? Those don't always track into SHA property management. But I think as a strategy, Annie, if you're looking at partners, it might be tougher in King County because you have a lot of different municipalities and we just have SPD and our emergency response, but they're more than willing to help identify hotspots and tell us where they're going way too much, because they'll do that anecdotally, but we almost, just before the pandemic started, got to a point where we were able to get them to provide, reports of property addresses and how many visits they've made to each property, if not each unit, which was sort of a hotspot process. And they were happy to do that. And I think in the future we can partner even more with them because they've expanded that Health One capacity quite a bit.
And Sean, we are resuming that data share with Seattle Fire and Health One.
Yeah. Very, very helpful.
So we're at the 45-minute marker time. Camille, I'm not sure how much time you needed for. We have a couple more slides for you to chime in on the national perspective. But is there any other additional questions from the group? I don't see any hands up at this time.
Yes, I am going to invite Stephanie Spampanato. I struggle with that name to share her thought that she shared in the chat.
No worries. You always manage my name beautifully. Don't worry about it. I was just thinking because during the COVID and the CARES Act monies, etc., we at the Housing Authority of the City of San Buenaventura put in security guards 24/7 at our senior buildings, precisely because there were a lot of visitors to our property, shall I say, sleeping in hallways, laundry rooms, computer rooms, etc. So that alleviated that. And then when the CARES Act money kind of dried up and the security was taken away, we moved more towards like our resident caretakers, just keeping more of an eye on the building. So I just wondered if there was a way to have a little group of resident caretakers just doing a kind of monitoring of who enters, who exits the building. Because I know that our property managers worked with residents to say, okay, who's your official caretaker? Who's your official in-home support worker? Who's your official social worker? And sometimes the names change, changing staff. But we had a basic list of authorized visitors to our one and only high rise, which is only 7 stories. But that went quite some way to alleviating some of the problems. So I was just throwing that out there.
Stephanie. Shelley, do you want to share?
Yes, I have a question. My question is, to what extent, what's the relationship between what's going on in our housing related to our residents and behavioral health matters and the interaction with the homeless communities in their areas?
Jake, did you want to take that one?
I was going to say, yeah, panelists, who wants to take that?
So, Shelley, can you repeat the question? I didn't understand the specific question.
I'm specifically asking about what is the interplay between the surrounding area of buildings and groups of or individuals who are homeless and the behavioral health problems that we have in our buildings? Or is there one that you've noticed?
Yeah, there is one. I think I understand a little bit better now. So what we are finding is, and this, is what's going on in the city of Seattle. Most of our properties have either a homeless individual or homeless camps in or near the properties. And what we find is many interactions are going south or negative from either people coming into the buildings, living in the buildings, boarding in the buildings, sometimes drugs. We've also had some major fire events. Next to or near our properties, we've had a lot of property damage. I think all of this stuff is increased trauma for our residents in our buildings. And so in already trying in difficult times of, going through 2+ years of a pandemic, I think it just adds another layer of challenge for our residents to maintain their independent housing and stuff, Shelley. That's the best answer I kind of have. It's just a complicated mix. And we don't have the resources that we had before to address these things, and there are more incidents that are happening now than were happening 3 years ago. And so I don't know if that helps answer, or I don't know if the panel has more to add.
I would go ahead and chime in a little bit more about that to your question, Shelley. What we often do see is sometimes homeless individuals will kind of latch on to some of our more vulnerable residents. And sometimes those residents' units have become compromised with boarders and lodgers. And so, how do you head that off? A lot of times we run into sticky situations where they're being recognized as a guest to that resident's apartments. And so oftentimes police, SPD will not intervene to remove an individual because they're there on an invitation from a resident. That's kind of a harder area for us to sort of lease enforce and sort of, head off before something like that happens. It could become a growing problem. For one of my properties in the north end, we had a large encampment that was on the other side of the freeway. This was a large kind of a wilderness area that had a very sizable encampment. And that encampment was creating a lot of problems. I'd often find individuals running an extension cord from our building just across the fenceway to the encampment. It got to a point where they were throwing lit incendiaries, like cans of like spray paint, WD-40, things like that. I was getting reports. We put 24-hour security there to make sure that we were kind of keeping the hallways clear, and the residents had somebody who was present to call and just kind of monitor help management. So that's just one pocket of kind of numerous amounts of other encampments that are close by all our other properties, but that one was pretty significant. So it has those effects when you have it close by like that. So
let me ask a follow-up question, if I may. Have we ever thought about, have we ever done building census, where we basically are going door to door and checking who's in the units in relationship to what the lease allows? Would that provide us any benefits, do you think?
There are certain. This is Jake again. Shelley, I think there's some challenges and hardships from that particular approach. We have done something akin to that when we've had emergencies at buildings, but residents are allowed to have guests at any given point, and there are even rules about how long they can have for guests. And so what you would gather in that meeting and how you would use it and what it would tell you. And of course, Shelley, our size. There are 3,200 units in 28 buildings. It's something worth talking more about, but it also would come with some severe challenges, I think.
Well, to loop back into kind of Stephanie's point about tapping into the caregivers network, that's kind of where we triage it with, social services who manage and kind of also oversee to make sure that the caregivers are doing their work. And then there's that oversight. Washington State does have the caregiver program that they have to clock in with a GPS location system. So we know that they're actually at work and at their clients' homes doing their work that they need to. But we do talk with a lot of community members. I have a lot of residents who keep me informed about a lot of things. And sometimes it's kind of piecing together. It's kind of a big jigsaw puzzle sometimes when you want to kind of figure out what's going on and what's the accurate story when you hear about incidences that occur. So I just want to make sure I acknowledge Stephanie's question. I see another one in here about another chat box in here from Edwin. The question reads, do you have formal agreements with your mental health providers / partners? ? If you do, can you share a template? Okay, so it's a sharing a resource question there. So Edwin, we can, panel, do we want to go ahead and answer that question first?
Sure, I was just going to say, yes, we do. We have, we put out requests for proposals every 5 years or so as our existing contracts begin to expire, requesting interested parties to provide on-site case management, care coordination services and supports. Along with those contracted agreements, we also do data sharing agreements to make sure that we're able to share information reasonably back and forth. HIPAA laws still apply, and we don't have any HIPAA workarounds. Sorry, I'm in an active office this afternoon. And we're happy to share a template with you. Our partnership with Aging and Disability Services is via an interlocal agreement, but all of our other partnerships are on regular contracts.
Excellent, excellent. So with the 5-minute mark, I wanted to make sure that we kind of wrap things up here. There are a couple of more additional slides that I'm inviting Camille again to go ahead and join with us to kind of share. So I don't see any other hands raised. I think we're good to move on from the Q&A.
Sounds good. Next slide. Great. Well, just in closing, we know that there are many challenges happening across our communities, and we wanted to talk about what we're hoping to do as next steps as a support for you all. So we at CLPHA have been talking with HUD also about the behavioral health supports that you all are needing and requesting. And I am excited to share the White House Mental Health Initiative, which was announced in March and has a number of pieces, there we go, that hopefully will particularly support our PHAs across the country. We're keeping an eye on it with HUD of how we can leverage these resources to be of benefit for you all. 2 things to particularly note that HUD's doing in support of this initiative is training social and human service professionals in basic mental health first aid response skills. This is talking about housing counselors as well as property managers for the PHA to give them some of this basic training that is used across the country. But alongside that, there is funding to not only build up the mental health workforce, but also embed and co-locate mental health and substance use professionals into community-based settings. Speaking with Rachel a couple of weeks ago, we're also really thinking about how we're getting people to be able to access these mental health services, building the connections, and building what those services will look like in our communities. So I'm hoping everybody will also keep an eye on this initiative as it's being rolled out from the federal government. And certainly we at CLPHA are going to be communicating back to you all in our network about what we're hearing from the federal government. So Stephen, do you have any final remarks you'd like to make, or would you like me to close this out?
Just want to go ahead and say thank you to everyone for joining and allowing for the panel and SHA folks here to give you guys a brief presentation about everything, and thank you all for your questions. And then that's it.
Thank you all for joining.
Thanks, everyone.